Begin with Professora Aida Mendes Cruz. She is the president of Nursing School of Coimbra, and she's the former president of the Phi Xi Chapter. Thank you so much, Professor. She's also a coordinating professor at the Nursing School of Coimbra. She's master in occupational health and doctor in education. So in the next 15 minutes, Professor Aida will be talking about the possibilities after chaos. So the opportunities that the pandemic generated to rethink nursing education. Please, Professor Aida, the floor is yours. Thank you so much for being here.
Thank you, Filipa, and good afternoon and good evening to the participants in this webinar. It's a pleasure to be here with all of you, and I am very pleased to have this opportunity to discuss with all of you these challenging times that we face at the moment. I'm going to put a presentation in the, okay. Do you can see this?
Yes,
okay.
we can.
Okay. So this graph shows the evolution of the pandemic COVID year in Portugal and in the European Union and the United Kingdom. As you can see, nowadays we are perhaps starting the fourth wave of the pandemic. We had one first wave at March and April with a peak of cases in 10 April with 1,500 cases. A second wave in October and November with a peak of 7,500 cases at 4th of November. And this second wave never decrease, total decrease. We have a third wave at December 2020 and January of this year, with a peak of 16,000 of cases at 28th of January. This wave has an abrupt decrease and maintains decreasing till now. And now we are perhaps facing the fourth wave. As we can see, this pandemic has impacts not only in the mortality due to COVID, but in the mortality of all the causes. And as we can see in 2020, the excess mortality for all causes was always above the average of the last years. However, in 1920, in this year, the vaccination has greatly increased in the last months. And we hope that this have a positive effect on the mortality. As you see, we have more cases, but the mortality is now very low. So what kind of consequences has this pandemic here? We can note that we have implications or consequences in the community and in the general population, in the health system, and of course also in the nursing schools. At the community and in the general population, we can note that the first time the fear was very prevalent, And nowadays we note tiredness and frustration. Fear, tiredness, and frustrations, emotional states that lead to disruptive behaviors in leading with pandemic and keeping the mental health. So it's a problem that we must be in touch. In the health system, we saw the closure of the no COVID service. This is perhaps one of the causes of the mortality for all the causes, because the access to the services was difficult during these years. And also they taken measures to decrease the number of people per service, and that has como consequence cancellation or severe restrictions on to assess clinical teaching settings. And of course, we have also impacts in the nursing schools. In nursing schools, it was necessary to take measures, individual and collective protection measures, such as telework for a lot of people in the school. We have to take behavioral roles for preventing the spread of infection. We need to suspend it for a period of time, the face-to-face classes, and we need to have digital and emergency remote education for a while. This moment leads us to an opportunity to rethinking nursing education and to put to ourselves some questions. We need to ask to ourselves, given this situation, how can we guarantee the continuity of the courses? Because there are students in school, they have the expectations to finish their classes, and the society needs new nurses every year. But at the same time, we need to guarantee the quality of the education that those students have. And in the other hand, we need to ask to ourselves too, which of the measures that we have taken, which of them are temporary and which of them will remain in time. To ask these questions, it is necessary to understand our point of view. And it's necessary to put in perspective. We have a school of nursing in Portugal. It is necessary to understand how is the nursing and the education of nursing in Portugal. So in Portugal, nursing education is in higher education. Our course has 4 years of studies and 214 ECTS. We need to have an accreditation. The courses, all the courses must have an accreditation for an independent agency, A3ES. And the most teacher of our schools, we are nurses, but we don't belong to the nurses career. We belong to the higher education teaching career, and this causes some contradictions in our work. For the other side, we have nursing as a self-regulated profession, and because of that, the courses must have a positive opinion from the Portuguese Nurses Council, Ordem dos Enfermeiros, because this is a requirement from the independent agency. And Portugal is an European country too. And because we are an European country, there are European directives that we must transpose to the Portuguese law. And we have a European directive about the nursing education. And in this directive has two ways to be a nurse. On one side, we have university courses with general education of 12 years and courses in the university. And at the same time, we have the possibility to have nurses with only 10 years of general education and given a training program in vocational schools. This directive is from 2030 and seeks to frame two distinct realities: higher education on the one hand and vocational education in the other hand. But when we read the complete directive, we understand that the explanation fits into a mental scheme specific of vocational education. As we can see, despite the conceiving the possibility of nursing of university education, the description of this directive is the same of the directive of 2005. This paragraph is the same that it was in the directive of the 2005. And in this paragraph, this is the requirements to the nursing education. It says that it's a course of 3 years at least, with 4,016 hours of total of the course, and half of these must have to be in clinical training. And when they explain what is clinical training, the directive says that these 2,300 hours must be done as part of a team in a direct contact with a health or sick individual or a community. So, in short, we have a directive from 2013, but essentially maintains the nursing vision of the 2005 directive, namely the possibility to assess with 10 years of general education, the possibility to have a vocational education, and a requirement that is not in SETS or in the logic of higher education, but in the logical of vocational education, with the prescription about number of hours being taken in these courses. From 2005 and 2021, we have 16 years, and in the meantime, much has changed. So we can, when we read the directive, we note that that directive supposes a dichotomy between theoretical and clinical learning. However, we know that clinical learning must be supported by solid knowledge, and must be understood that a way and integrative way to learn theory. We know that clinical learning is not just the domain of doing, and to develop the critical judgment can be trained in other contexts than the described. So we can rethinking this education in this framework to the education in nursing in Europe, and we need to ask to ourselves, it is possible to learn nursing, that is a relational profession, using distant learning methodologies. Is that possible to learn nursing with this methodology? And if so, we must to understand what can be the contribution of this type of methodologies. And at the same time, we need to regard that nurses need to make decisions in great complexities. We should not look at nurses not only in the domain of doing, but also to think. Nurses must to think and must make decisions and take into account the knowledge and the individuality of the other. So we need to put in the paper that nurses need to understand concepts, nurses need to generate original ideas, nurses need to use logical approaches. At the same time, we know that knowledge is not static, and that's a very important competence for nurses and for the students of nurses, to learn. On the other hand, we know that learning is a social process. Learning, whatever is the learning that we have in hands, but learning nursing, for all the reasons, is a social process where the contact of the teachers, the contact of the teams, the contact of the other students are very, very important. So going back to the implications of the pandemic. At the first time, we made a rapid adaptation to the systemic and contextual changes. It was an emergency, and we do it. But at all this time, we regard that we have a high dependence on health institutions to perform half of the learning program. And this dependence with the closure of the units and the difficult to assess of the context brought a lot of difficulties to the learning program. It is necessary to rethinking this component of our education. And I think that the clinical component of learning should be understood as another teaching learning methodology, and not as a learning time in which the student mimics what the teams do. At the same time, we learn that the distance learning is not teaching traditional classes using a computer. Distance learning is another thing than that, and we are very clear thinking that our teachers needs a lot of education in this type of methodologies. Nowadays, we have at our disposal laboratories, problem-solving techniques, reflective thinking training, and many other techniques and methodologies that ensure the skills for scientific and autonomous nursing. The nursing education today has a lot of possibilities that doesn't have in the last century. So by a way of conclusion, I will say that the most important thing that we must face is so that the society does not waste the skills of modern nurses. Nursing education and professional framework cannot remain bound under the rules of the last century, just like the directive nowadays insists. Thank you for your attention, and I will be here for the asks that you want to put. Thank you.
Thank you so much, Professor Aida. And I would like to ask to our participants if they want to to pose any question to Professor Aida. If you want, you can leave your question on the chat and we will read it. Okay, maybe we can move on and then we'll pose the questions after all the other participants. Is that okay? Okay, I think we can move on. Thank you so much, Professor Aida, once more. And now, I am very pleased to present Dr. Seah Betsy, and she's a research fellow in Alice Lee Center for Nursing Students, Wong Long Lin School of Medicine, National University of Singapore, and as a registered nurse, she worked in one of the Singapore's busiest emergency departments in Tan Tock Seng Hospital. So in the next 15 minutes, Dr. Seah will talk about the impact of COVID-19 on pre-registration nursing education, so a Singapore perspective. Dr. Seah, and I know that the time zone is very different, and if necessary, we can ask the questions right after your communication. So please tell us what do you prefer. So thank you so much, and the word is yours.
Okay, thank you, Anna. I'm okay to have the questions after after every speaker speaks. I'm fine with that. Yeah. So let me share my screen. Okay, let me know if can you all see it? Okay, that's great. Okay, so a very good day to everyone at the other side of the screen. Okay, so I'm Seah Betsy, both a research fellow and a teaching faculty member at Alice Lee Center for Nursing Studies, National University of Singapore. So it is my great pleasure to speak at the 5th edition Phi Xi Talks, among other established speakers here today. So I'm going to share about the impact of COVID-19 on pre-registration nursing education, particularly on how we cope with the sudden bombardment of the coronavirus and how we plan to move on and live with the virus from the Singapore's perspective. Now, at this point in time, some of you might be thinking, where is Singapore located? So Singapore is located at the north of the equator in Southeast Asia. So we are an island city-state with a small land area and population size of 5.89 million. As such, we have very high population density. And if you do step into Singapore, you'll notice many high-rise buildings and residential estates. So our university is Singapore's flagship university and one of the leading universities in Asia. And we are a relatively young nursing school. Our department, Alice Leaf Center for Nursing Studies, was established in 2005 to offer Singapore's first Bachelor of Science nursing program. And today we offer a range of undergraduate and post-graduation programs, as well as continuing education and training. So our BSc nursing degree is a 3-year undergraduate program, and students who perform well, they will be able to proceed to the 4th-year honors program to take on an independent research project. So our research actually encompasses 4 different specialty areas, as you can see there. So for further information on our nursing school, you can visit our website here or scan the QR code. So this is Singapore's epi curve at the very early stage of the pandemic back in January 2020 when we received our first imported case. And in early February, when we had multiple local community cluster outbreaks, which led to the announcement of DOSCON from yellow to orange. So what is DOSCON? So DOSCON actually stands for Disease Outbreak Response System Condition. And this is actually a color-coded framework which guides the scale of outbreak response Singapore takes. So this change of color code led to a series of control measures that have significant impacts on the nursing education in Singapore. So yeah, this is the color code framework. And like many nursing institutes, and as what the previous speaker has shared, the delivery of our nursing education constitutes lectures, hands-on experiential learning in clinical skills laboratories, followed by assessment of knowledge and clinical competence, and finally, having to send our students to clinical areas for the real exposure with patients. However, with the announcement of the DOSCON Orange, all students and staff have to exercise social responsibility, adhere to strict social distancing, and minimize interaction with each other. And to limit movement across academic and healthcare institutions, all clinical postings were suspended. So at that point in time, our graduating 3rd-year nursing students were into their final phases of their 9-week clinical posting. And as such, we had to convert all our lectures and large group tutorials to e-learning. We had developed and used videos to teach clinical skills. And only a very small group of face-to-face classes were allowed for final year nursing students to replace their clinical practice. And we had to modify the way how we assess our students formatively, convert to online examinations, as well as having to use simulation to replace clinical practice. So in the rest of our presentation, I will share about our experiences and reflections in overcoming these 4 aspects of change. So indeed, COVID-19 pandemic has been a catalyst for digital transformation in nursing education globally. And the transformation to 100% e-learning was significant despite our initial intentions of embarking on blended learning at the start of 2020. So what took us this long to have this sustained digital transformation within such a short period of time? So we contributed this phenomenon to the operational alignment of these 3 factors. So mainly goals, resources, as well as capabilities. So what do we mean by that? So for goals, there were clear top-down directives from the university leaders to disallow large face-to-face classes and to encourage us to use technologies. This aligns with teaching and learning with both organizational as well as the public health goals. And the university provided technological gadgets such as webcams, headphones, as well as to introduce and provide ongoing pedagogical training on the use of various educational technological and communication tools such as Zoom, Microsoft Teams, to allow us to experiment remote virtual learning as well as digital assessment. And more significantly, we had direct support and constant feedback loop with our IT personnel to troubleshoot technical issues as well as to cater to our different teaching styles and students' learning needs. So at the heart of it really was the importance of continuous learning and relearning of faculty members. We have to monitor our students' usage of these e-learning platforms. We have to evaluate and refine the way how we deliver our curriculum. So many of us actually went with a very open mind, and we had that let's give it a try attitude. So apart from teaching clinical procedures and skills via Zoom, some of us had to search for or even develop our own videos for clinical teaching. And it made us realize that many of our existing videos were either not detailed for independent self-directed learning, or they were not contextually or culturally relevant to our local clinical settings. So to ensure uneventful conduct of online high-stake exams, we will use low-stake formative assessments such as quiz as practice tests. So this actually allows us to surface and tackle operational issues that arise. And as a result, we also establish an online exam support chat group maintained by administrators and IT support staff to address immediate concerns during the high-stake exams. So apart from using online proctoring to deter cheating, the university also allows students to write off grades for up to 10 modular credits. And these write-off modules will not be calculated into the students' total score, or what we call as a CAP score. So this actually helped to ease our students' anxiety to perform well in times of the pandemic. And the university also had put in place very strict disciplinary actions as a form of deterrence for academic dishonesty. So actually a larger concern that's related to nursing education will be the challenge of assessing soft skills such as communication. So for our school, we actually use Zoom and standardized patients to conduct real-time online communication skills assessment. So in each breakout rooms, for a Zoom breakout room, we have the assessor, the standardized patient, and the student who was taking the exam. So to create an authentic clinical environment, the standardized patients actually wore hospital clothes while our nursing students wore their scrubs at home. So what you see here, the first picture is actually our standardized patient showing this nursing student his risk tag so that the nursing student can actually check for two identifiers. So when we came to know about the suspension of clinical postings, apart from being shocked, our next best alternative was to use simulation to replace clinical practice. So existing evidence has shown that equivalent outcomes in clinical competence, as well as students' readiness to practice, were prevalent when we substitute clinical practice simulation we substitute clinical practice with simulation for up to 50% of the traditional clinical hours. So actually in Singapore, to qualify for professional RN license, our final year nursing students have to fulfill 400 hours of clinical practice. As such, we actually sought approval from a Singapore Nursing Board to replace 160 clinical practice hours with simulation. And so this translates to 4 out of 9 weeks of the clinical practicum for our final year students. And the plan was to resume clinical posting for the remaining 5 weeks in hope that the COVID-19 situation improve. However, having to run 160 simulation hours each for 300 nursing students is challenging. Not only were we constrained physically by our limited simulation facilities, we had to adhere to strict safe distancing measures, and the maximum number of students that we can have per class is only 10. So having to replace 1 hour of clinical practice with 1 hour of simulation for high fidelity simulation is not practical. So we look into the literature for recommended education practice on the substitution ratio as well as modality of simulation. So while there's this review that identified 1:1 ratio as the most frequent ratio, and that high fidelity simulation was most commonly used as a modality to replace clinical hours, there wasn't really clear evidence on the recommended education practice. However, there's one study that employed 1:2 substitution ratio, citing that simulation is controlled and time compressed, and therefore should be more than parity in terms of clinical practice hours. And due to our limited simulation facilities and time resources, we decided to adopt the 1:2 ratio and explore a variety of simulation modalities. Hence, we adopted three modalities of simulation. There's high fidelity simulation, procedural simulation, as well as computer-based simulation. So these three forms of modality actually accounted for 80 simulation hours to replace that 160 clinical practice hours. So to prepare our final year nursing students for their clinical practicum in transition to be a graduate nurse, we implemented a simulation program known as a SIMPLE program, which was developed by my colleague, Associate Professor Liao Sok Ing. And there were a total of 6 sessions, each focusing on a particular theme with specific learning objectives. So they actually cover common nursing activities such as patient admission, how to prepare a patient for operation, how to hand over to colleagues, how to prepare medicine, communicate with doctor, even to prepare for discharge and how to manage death of patients. So after each simulation session, students had to submit a reflective log to consolidate their face-to-face learning via reflective practice. So these reflections were also included as part of their assessment grade. And so for simulated patients and relatives, they were recruited and being trained using a detailed script to role play. So each session was facilitated by our faculty staff by adhering to the facilitator guide. And this guide actually outlines clear learning objectives, the lesson plans, the descriptions of scenarios, as well as the briefing points. So note that all these photos were being taken before the COVID-19 pandemic. So in view of the initial uncertainty of how the pandemic would pan out, we also came out with contingency plans on having video-based simulations in the event that if, let's say, no face-to-face small group sessions were allowed. And therefore, we actually sought permission from our students to video record the simulated sessions. And this is with the aims of playing all these sessions via Zoom, and the facilitator could debrief with other students who didn't have the opportunity to attend face-to-face sessions. So such form of simulation were at best offering a very convenient and cost-effective approach of facilitating remote learning of clinical practice. And fortunately, the COVID-19 situation in Singapore improved, and we managed to run all 6 sessions face-to-face. So to encourage self-directed practice of clinical skills, our third year students were issued individual sets of common nursing requisites and and they were allocated time slots at the clinical laboratories to practice and also to bring these requisites to practice at home. So their clinical skills were being assessed via video recordings of any 10 nursing clinical procedures using simulated clinical setups. So what we have here are some images of the videos that our students submitted for their video assessments. And we definitely see the creative juices of our students at work. So for example, like one of the students used clothes pack and sticky notes to perform ECG on patient. Another actually used a soft toy to perform intramuscular injection, or even to print images to simulate certain anatomical structures. So where incorrect clinical skills principles were observed, students were asked to resubmit their corrected video recordings so that their clinical techniques and principles were grasped correctly. And owing to the sudden implementation of a lockdown, or or rather we know that as a circuit breaker in Singapore, we were not able to conduct our usual OSCE assessment to evaluate students' clinical competencies. Instead, we conducted a virtual assessment via Zoom on the donning and doffing of personal protective equipment. So this skill was particularly chosen to reinforce infection control techniques before sending students to hospitals to complete their remaining 5-week clinical posting. And yes, fortunately, with safety measures in place and as well as the approval from our Ministry of Health, clinical posting was allowed during the lockdown period. We also incorporated 2 computer-based simulations. This virtual simulation program, titled eRapids, as you see here, was developed to enhance students' development on clinical reasoning skills. And students were presented with various case scenarios with the patients having deteriorating conditions, and they'll be guided by this platform to perform virtual clinical assessment and interpret findings to provide appropriate care management for their patient. So this entire learning experience takes up to 3 hours. And the second computer-based simulation that we incorporated was recently established, and it actually aims to develop interprofessional communication among students from various healthcare professions. So this virtual reality simulation is titled Creative. In short, it involves various users to log into a virtual platform remotely and interact with each other on the simulated role play case scenarios. So behind all these avatars that you see on screen are our nursing students interacting with other multidisciplinary healthcare students, as well as our trained standardized patients and our facilitator from the faculty to guide the entire session. So like many healthcare systems across the globe, COVID-19 has caused a shortage of healthcare workers in Singapore as well. So some of our final year nursing students volunteered as phlebotomists to assist in mass testing serology efforts. And although we offer this opportunity to our graduating students, only 31% of them volunteered. As such, we wanted to find out what influenced their willingness to volunteer and how we can improve this volunteering uptake. And one of the recommendations by students was actually to integrate such service learning opportunities with the nursing curriculum and include them as part of clinical placement hours. So while such form of learning has been included in some of our in some healthcare institutes in the United States as well as in Europe, this is also a form of educational modality that we can think about for future pandemics. Of course, I do hope that we will not have any pandemic in future. And so, it has been more than 1 year since coronavirus actually intrude into our lives, and we are still learning how to live with it. So although clinical postings in Singapore have resumed, for all students, we had to replace our specialty postings such as emergency care as well as mental health, because these are more at risk or vulnerable groups of patients, with face-to-face simulation sessions. And we strongly encourage all our students to get themselves vaccinated prior to their clinical posting and continue to adhere to strict public health measures. So we are moving towards hybrid teaching, whereby we actually receive feedback from students that they value the social interaction as well as that face-to-face peer learning experiences drives learning. So we heard that, and we are moving, and therefore in the upcoming semester we are embarking on this thing called hybrid teaching, whereby we'll have half of the class attending face-to-face lectures or tutorials and another half of the class attending online synchronous lessons. So these two groups of students would then alternate so that they can actually get to come to the campus and meet up with their peers and engage in learning together. So more importantly, how has this pandemic experience has prompted us to, like what the previous speaker Prof has mentioned, it has also helped us to rethink about how we deliver nursing education. And in particular, it draws attention to remote teaching as well as practicing of clinical skills using sustainable and effective strategies. So some of them would include to firstly, to establish operating systems so that we existing multimedia e-resources on clinical skills are of high quality for learning. And with telehealth becoming more prevalent in the clinical settings, it is also important to think about how we can develop students' virtual nursing competence so that they can be telehealth ready in future. Another area to explore will be the development of virtual reality simulation platforms and the adoption of artificial intelligence technology for clinical skills learning and assessment as a supplemental form of training. And as mentioned, service learning could be an alternative modality of clinical training. However, this will definitely require very prompt and responsive partnerships between nursing schools and hospitals or even community partners to render such services. And it also makes us think about how we can increase the resilience of nursing education systems by considering various system redundancy strategies. So in this way, we can actually continue to deliver effective clinical teaching even when our primary mode of clinical learning through clinical posting fails. And last but not least, we have learned that change is the only constant, and there is thus a need to constantly review and calibrate and adapt our pedagogical approaches in response to the pandemic changes. So we need to be responsive, yet at the same time to be able to stay relevant to clinical practice. So I'd like to take this opportunity to thank my colleagues, especially Associate Professor Liao Sok In, as well as Associate Professor Lydia Lau for their slides contribution, and as well as Professor Emily Ang, who is also the head of our nursing department. So what you see here is our publication that I've largely shared about. You can refer to it if you are interested. And I'll come to my end of my presentation. Thank you all for your kind attention.
Thank you so much, Betsy, for your fantastic presentation. Thank you. And considering, of course, your time zone, can we put now, or we can now put questions to Betsy. So let's hear our participants.
Okay.
Maybe, okay, thank you so much. It was great.
Can I
Yes, please,
make a question? Dr. Betsy, I'm really impressed with your communication and all the strategies you took in your university to adapt to this new reality. And if I understand, if I understood right, you said that your students practice the communication competences with patients. Am I right? On Zoom, they Zoom with patients for training communication communication competences, right?
Okay. Thank you for your question.
No, I
So
didn't feel. I was going to ask you, what was the criteria that you took for choosing the patients, and if it was easy to get that patients to do the practice.
So actually, so we have been using rather than real patients, we have been using standardized patients. So standardized patients refers to this group of individuals who are trained and through our specialists, and they in each scenario. We will have to design the scenario, and there'll be scripted role play in terms of what are our learning objectives. So so they are not real patients, they are standardized patients. Yeah.
Okay. Okay, thank
So
you.
yeah.
Thank you so much, Betsy. So we have other question from Peter, and he asks, how could you get the resources for the development of such diverse e-learning tools in such short time?
Okay, so we were, I must say, we are very fortunate. Our university actually had at this center for
Simulation?
CDTL. Okay, there's this particular center in our university that actually provides training for all faculty members in terms of pedagogical use of pedagogical approaches, as well as various ICT tools. So so with that itself, at that point in time, the entire university is moving towards blended learning. So we were having the idea of having to conduct half of our classes in online and half of our classes face to face. So that initial start helps to kickstart that. But of course, the learning curve was still very steep for us. So there was this period of time whereby we constantly received a lot of emails on trainings by the department, the Center for Development and Learning and Teaching. Okay, we actually receive a lot of emails from them telling us, okay, you can use this particular software, you can use this particular software. So we were being exposed to it. So it is from there, then we actually pick up, okay, this might be relevant to us. Then we actually pick up on the various ICT tools, and we learn how to use it. And training was being provided by this particular department in our university.
Thank you so much, Dr. Betsy. So we just have one more question I will pose to you, and then I will leave this question also to Professor Aida at the end. So what do you think about the skills of the students as a result of this new approach?
Okay, so we must say, and we must together with my colleagues, we admit that this coronavirus has hit us suddenly, and we have to respond to it so quickly. So we felt that at best, whatever approaches that we actually use we were using our resources at best to actually cope with the situation. So like, for example, having to use allow our students to use simulated clinical setups, that is definitely not the ideal, but at least the students have some form of practice at home, so that when they transit into the clinical area, they could have that some form of skill, that first-hand experience before they move out. So that's we are moving towards that's not the best option, but that's what we have at that point in time.
Thank you so much. And a last question. So have you measured other factors that may have affected the students' responses to learning, for example, stress or fear?
Okay, so at the moment, our school have not we do hear from our students that there were a lot of anxiety initially when we actually transit from into 100% e-learning. So we had a few forums, we conducted a few forums with our students, and we hear from them what were some of the challenges and difficulties that they face as they use the various e-learning platforms, as well as the various pedagogical strategies we used. And from there, we try to address their concerns. So we try to get some form of feedback from them. And I think I also have a colleague who has plans to embark on, to evaluate on home-based learning for nursing education. So we're looking forward to his results. Yeah.
Thank you so much, and for your great presentation and also all the answers. Thank you. And so we can now move on. Let's present dear Professor Brandon McCormack. He's the head of division of Nursing, Occupational Therapy and Art Therapies, Associate Director of the Center for Person-Centered Practice Research at Queen Margaret University from Edinburgh, and professor in countries as Norway, South Africa, Slovenia, Australia, and Austria. So we are delighted to hear in the next 15 minutes Professor Brandon McCormack entitled with the presentation entitled Developing and Sustaining Person-Centered Learning Environments. Thank you so much, Professor.
Thank you very much, Anna, and thank you so much for asking me to join this webinar this afternoon. I'm delighted to be alongside everyone. I'm just going to share my screen, hopefully. Okay, that works. That's always a good start.
Yes, please.
Okay, so again, thank you for asking me to join you, and I'm delighted to be able to do so. And I guess I had got some comments to make about similar things to the previous presenters, but actually I think what I would just want to say is that the experience for us here in the UK has been very similar to those things that have been discussed earlier, including some of the technological advances and adjustments we've had to make. So I'm not going to readdress those things, but what I do want to do is kind of look at this from the perspective of the particular philosophical worldview that I come from, which is that of personhood and person-centeredness as a focus of learning for all nursing, irrespective of specialty. And so what I want to do in the first half of this short time is to use our theory, the person-centered practice framework that we use to underpin our curriculum and is used globally in many nursing and other healthcare curricula, to just raise some issues about some of the things that nurses and student nurses faced during the pandemic in relation to that framework and trying to retain a person-centered approach. And then to move on to some of the things that I think we need to do, which is coming through a European Erasmus project that I'm the leader of around designing person-centered healthcare curricula. So, oops. And I also just want to refer, what I'm talking about has probably been written more extensively in some of these publications, which are all available, and it kind of goes into more depth, because clearly in 15, 20 minutes, I just don't have enough time to cover any of this in such depth. So the person-centered practice framework is essentially a whole systems framework for looking at how we create person-centered cultures in nursing and healthcare. And as I said, it's used globally. It's been translated into about 13 languages now, and it's used in policy, in strategy, and increasingly in healthcare curricula. And the framework operates on the basis that to have person-centered care for patients and families, then we have to create person-centered cultures. And if we are going to do that, then we do need to do that systematically, and we need to pay attention to what's important. And so the framework operates from the outside in. At the heart of it is the idea of a healthful culture or a person-centered culture. But what are the things we have to pay attention to get to that kind of culture in all our settings? And on the outside are the macro context, the large political and strategic issues that we have to be paying attention to. During COVID, in relation to nursing students, then some of our biggest challenges here in the UK were to do with working with the regulators. And Dr. Mendes kind of really covered some of those issues about adjustment in practice hours, because we are, and then still are, even though we're not in the EU anymore, we still are regulated by the EU guidelines for our nursing education. So the practice hours and the adjustment of practice hours was a very contentious issue with our regulators. But also probably more significantly, I think, has been the challenge for me and my academic colleagues has been staff and student well-being during this period, not just in relation to infection, but also in relation to how we help them to cope with their program disruptions. Much of those disruptions have already been identified by the two previous speakers. The next layer in of the framework are the prerequisites. These are the qualities and attributes of the nurse and what the nurse needs to know and have in terms of their ways of being and doing in order to be a person-centered practitioner. And again, during the COVID impact, some of the issues that we were particularly challenged with our students were to do with some of their personal boundaries. How did they manage some of those personal boundaries when in clinical settings? I do have to say that we were very successful here at Queen Margaret University in that we managed to keep all of our students in clinical practice. And we did that through a huge amount of adjustment and reorganizing and working very much in partnership with our partners to ensure that our students could continue their learning. The only students who didn't were our first year students, but we took them out of practice for 6 months and made it a completely theoretical year, but then readjusted that in their second year, but every other student stayed in practice. So we also saw in relation to some of these things, issues to do with values conflicts with some of the decisions that they were caught up in that they wouldn't normally have been caught up in. And everyone before me has talked about the issue of having to shift to an online resource. I do want to just make one comment about that, which is that here in the UK, we have an online university called the Open University, which is one of our biggest providers of nursing education and has been for many years. So they have well-established systems and processes in place for distance learning for pre-registration nursing education. So there's a lot to be learned from them, and I think we all did learn from them during the pandemic as well. Some of the other issues I want to raise in relation to prerequisites of the students has been the last bullet point in the COVID impact section, which was some of the personal sacrifice that many students had to make in relation to being really having to stay in halls of residence without any family for the period of the pandemic, and how we support them during that. And also the sense of loneliness and isolation that they experienced. So whilst we may all confidently say we adjusted our learning approach for our students, I don't think the impact of the loneliness that many students felt during this period has yet been seen in terms of its full impact, and something we really do need to pay attention to as we move forward. In terms of the care environment, which is the context in which practice takes place, and again, these are the elements of context that we think are important for a person-centered culture to be developed. In terms of COVID, then, of course, there were big challenges around student supervision and mentorship, and how we could sustain those mentorship relationships. In the UK, there was a particular challenge because the chief nurses of the 4 countries of the UK agreed that our students would lose their supernumerary status for a period of time and would become paid employees. And that caused huge problems for us. So that happened during the first lockdown period, but over the second lockdown period, us as in the higher education sector refused to comply with that happening again, and we didn't allow our students to be taken out of supernumerary status or to be paid. I could say more about that, but it was a huge complication and had quite a negative impact on student learning. We also saw a lot of discontinuities of, because mentors were going off sick or were no longer able to provide work, then it meant that students didn't have some of the continuity they would be used to having. And of course, we had to engage in a lot of risk assessment and really make very careful decisions about the risk we knew we were taking, and that our students were continuing to go to clinical settings where we knew there was a lot of COVID, and how could we protect them. And then in terms of person-centered processes, which is really the person-centered care part of our framework, this is really about how we practice with patients and families. Again, during the COVID period, I think our biggest challenge in relation to this was about balancing the expectations and values of the regulator with those of the higher education institution, the university, but also with student values and expectations and what they thought was right or not right in these kind of situations. And that required a lot of careful negotiation and communication. But I do think one of the real benefits that's come out of this whole experience has been the way that everyone has adjusted to more creative means of teaching, learning and assessment. And we've heard some of those in the previous speaker. And again, many of those are familiar to us in that we've been doing those. But we have made a lot of use of virtual reality and simulation in changing the way that we connect students with patients. And so we managed to continue our clinical skills development through simulation and virtual reality, and also the assessment of clinical skills through virtual reality. And the question earlier about how that impacts on student practice, I think what we have as evidence for that is that our students have all achieved their learning outcomes for these, and that's the marker that we have to use in relation to the effectiveness. So that's a very kind of quick overview of some of the key issues that I think have been particularly significant during the COVID period. And I just wanted to pull those out because they build on the 2 previous speakers' comments about what we have all experienced. But I also want to move now into thinking, well, what does this mean for us as we move forward? Because I think we can spend too much time just looking at what were the issues, but actually I think now what we have to do is to focus on that now common phrase of build back better. There is going to be no return to normal. That normal is very much gone, and it is about creating a new context. And I am I do a lot of work around Theory U and the work of Otto Scharmer around how we change cultures and how we change practices. And Scharmer has suggested that the coronavirus pandemic has provided us with an opportunity to stop and reflect and to think about how we want to go forward. And in our case, how do we want to go forward as a nursing profession? And Scharmer argues that this period of reflection enables us to move away from systems that are driven by ego, which is all about power and responsibility and authority, to cultures and practices that are based on eco and ecological systems. So how do we create ecological systems where actually we place front and central many of the values that are commonplace in nursing, such as care, compassion, kindness, respect, and all of those kind of things. And for me, that is fundamentally about what person-centered curricula is about. I do think networks such as Stigma are critical to that ecosystem, and our international community of practice for person-centered practice is also part of that ecosystem, where we do a lot of work around helping to really understand what person-centeredness really means. And I'm very welcome for you to contact me if you're interested in joining us in that now global community. You would be very welcome to come on board. So as part of that ecosystem and as part of that change, I am currently leading a program through the Erasmus Plus framework, developing a curriculum framework for educating person-centered healthcare practitioners. And this is in partnership with Ulster University in Northern Ireland, Trinity College in Dublin in Ireland, Fontys University of Applied Sciences in the Netherlands, the University of Southeastern Norway, and the University of Maribor in Slovenia. And together we are designing a person-centered healthcare curriculum framework for nursing and other healthcare subjects to use to shape what I see as a sustainable person-orientated curriculum. The first 2 stages of our work have been published in a special issue of this journal, so you can access that easily. They're free open access, and that's the International Practice Development Journal. And we have published 4 papers as a collection to begin with, one around the global review of person-centered healthcare, and the second one, which is around the philosophical and pedagogical principles that are underpinning a pan-European curriculum framework. And then we have a third paper, which is some evidence of the framework coming through. And why we believe this is really important is that whilst most nursing curricula will espouse some kind of person-centered or human caring values in some way, what we do see and what the pandemic, I think, has shown us in really sharp focus is how easy it is for those values to disappear. Because our curriculum becomes focused on the technical aspects of care and the more humanistic, caring, person-orientated aspects of care move to the back. And we have to really, really think about how we want our curricula to look going forward, so that when something like a pandemic happens, that all we're left with are essentially the skills and the tasks. That is not what nursing is about, as Dr. Mendes said at the outset. So how do we create curricula that really sustain these kind of values in the foreground of what we're doing, so that when it comes to the practice, this kind of DNA of person-centeredness is built into everything that we're doing and everything that we are learning and teaching. So what is a person-centered curriculum? Well, we have defined this and we have tested this through a series of engagements over the last year with our stakeholders across the world, actually. And so we define a person-centered curriculum as a curriculum whose purpose it is to achieve transformation. So it's not a curriculum that's just about teaching things to students. It's actually a curriculum that is focused on transforming the perspectives of people who come on our programs. It has to be grounded in pragmatism as a philosophy. And pragmatism is a philosophy that's how do we embed values into everyday practice? How does everyday practice become the core of what it is that we're about? But that our curricula also are co-constructed, and they really must be co-constructed with our partners at all levels, And that what they are focusing on is creating connectivity with myself as a person, but also connectivity between learners and between communities along the whole of their learning journey. We used a framework called the McKinsey 7 S's to analyze what is currently happening in the world of nursing and healthcare curricula. And I don't have time to go into the detail of this, but one part of our program of work, which we have just literally completed last week, was to analyze nursing and health curricula from universities around the world, to analyze them using this framework, but to also, we did a series of stakeholder interviews with regulators, nursing leaders, university leaders, clinicians, students, to kind of dig into that definition of person-centered curricula and to try and understand what it really looks like and feels like using our definition as our anchor. And we use this framework to analyze our data, because the McKinsey S's is actually a gap analysis model from organizational science. And what it focuses on is trying to understand the gap that exists between what exists and what we want to happen in a very systematic whole systems way. At the heart of the McKinsey framework are shared values, which really resonates with us in relation to person-centeredness, because a person-centered curriculum is built on shared values, values of caring, values of respect, values of passion, values of competence, values of expertise. And so those values shape everything else there is about a curriculum. And one of the criticisms and one of the observations I would want to propose during this webinar is that one of the things that I think has really been difficult in nursing is that, and we have identified this through our analysis of our curricula, is that very few current nursing curricula are really based on a nursing theory or nursing model. The evidence-based practice movement has meant that nursing curricula have become very procedural orientated and become based on more generic evidence. And there is a huge issue for us in nursing in terms of re-owning that space of nursing theory and shaping our programs around and explicitly embedded in nursing theory. And so the McKinsey 7S framework really helped us to explore that. So what I want to do in the remainder of this time is show a series of slides that connect the framework to what we are now moving to in the development of a curriculum framework. And these are statements that have now been agreed and validated by stakeholders who have connected with us over the last year in a very systematic way. And it's these statements that we will now use in the final stage of our work, which is to develop an actual framework for a curriculum. And I just want to share with you each of these statements linked to each one of these 7 S's. I do apologize that there's a lot of text in each one of these slides because I couldn't extract out the key things. But what I have done is highlight the key words that are really important to pay attention to. So that would be the important stuff to look at and read. So the first thing about our curricula is that we do need a strategic approach to our curriculum framework that makes our curricula unique. And going back to, in terms of nursing curricula, we really do need to really critically look at our curricula in terms of their uniqueness compared to other professional groups. And we would argue from this work that the strategic focus of a person-centered curriculum is about developing person-centered learning cultures, is about developing competent and confident person-centered practitioners, and developing flourishing cultures that nurture authenticity and therapeutic relationships. And that our strategic focus in nursing is to have these 3 components, 3 strategic areas embedded in everything we do as nursing educators and in educating future nurses. In terms of structure, the structure of curriculum is really about how do we bring a philosophy to life through what we focus on within a curriculum. What are our intentions? How is the curriculum organized? What is it that we pay attention to? And again, every curriculum looks slightly different, but what we would want to say is that if we are going to espouse print values of person-centeredness or human caring or any of those kind of things, then they have to be like a golden thread through everything in the curriculum. It has to be the core component of everything that we're working with. But that also our curriculum has to be constructivist in that it has to build over time. In pedagogical terms, that's often referred to as scaffolding, scaffolding approaches to learning, where students are built over the 4 years of time, and that knowledge is co-constructed and systematically built over, in our case, 4 years. I think the same for you. But that curriculum, in terms of structure, also has to be co-designed with key stakeholders and especially co-designed with students. Our current curriculum here at Queen Margaret's for our undergraduate program, we spent almost 3 years as an action research project co-designing that curriculum with our students so that it was jointly written with them. And that evaluation has to be a continuous key part of it all, not just end of unit evaluation or end of year evaluation, but an ongoing systematic approach in everything that we're doing. In terms of systems, this is about the learning methods that we use and the teaching and assessment methods in order to achieve curriculum outcomes. In a person-centered curriculum, I think it's essential that we are able to articulate the philosophical principles of personhood or philosophical principles of caring or human science. And that philosophy has got to be explicit in every aspect of our learning, teaching and assessment. And our observation and our analysis of existing curricula is that that's not the case. What we saw in the 28 or so curricula that we evaluated is that most curricula have some kind of philosophical statement at the beginning of the document, and then it kind of disappears. It becomes a very technical curriculum. So how do we build curricula that really hold these philosophies central through all of the units of learning in our teaching and in our assessment strategies? And our learning and assessment really has got to be facilitated. One of the, I think, things that I think is a very positive thing that's come from the pandemic is that it has forced us to move away from a face-to-face lecturing mentality. And now we have realized actually students are capable of following these lectures online without a lecturer standing in front of them and telling them. And we can use that time more creatively to facilitate an engagement and facilitate in different learning strategies built on that knowledge. And that's what our curriculum has now moved to here. We will never return to face-to-face lectures again, but we will use that time for more facilitated engagement with learners. In terms of shared values, then we need to see curricula that do hold person-centered approaches as an explicit ethos of the program, not just as some kind of statement, but that it is very much explicitly stated. In our program here at Queen Margaret's, we have focused heavily on the learner's personhood, taking on some of the things that I've said about COVID, you know, where the student well-being, the nature of their learning, who are they as a person, is a critical part of how they develop. And so the first year of our curriculum is very much based on helping the learner to understand themselves. You will also notice I've used the phrase learner here, because in a person-centered curriculum, which is different to a student-centered curriculum, all of us are learners. So we are moving away from the language of lecturers and students to the language of co-learners, because we are a learning community, everyone learning together. And that's about learning with rather than doing to, and treating all of us as equal persons, no matter what hierarchical place we hold in the system. In terms of style, which is really about how the curriculum is led, what's the leadership embedded in the curriculum, we have very much seen through this work the focus on a collective leadership. It's not about the curriculum manager or the program leader or the unit leader or the course leader, but it is about everyone collectively working on managing the curriculum together. And again, in our context here, we have embedded our curriculum in a shared governance approach. So although I am the professor and head of department, that does not mean that I lead everything to do with this. In fact, I lead very little of it. It's led by the whole team and the students who are also part of that team. In terms of skills, we, in our work, and you will be able to access it because it will all be publicly available, we have identified a long list of skills that academic staff in particular, but also our practice learning colleagues need to have in order to facilitate person-centered learning. But fundamentally, what those skills are really about is how do we use those skills to create the conditions for all learners to flourish as persons, for them to flourish as human beings who are embedded and engaged and connected in their learning and in their practice. In terms of staff, which is really about the how do we work together as a person-centered team, we would argue very strongly that we have to embed the values of person-centeredness into the faculty as much as we are embedding it into practice and into students' ways of being and doing. If we as faculty are espousing person-centered values, then we have to also live by those same values. If we as faculty are espousing humanistic caring, then we have to be clearly demonstrating humanistic caring in the way that we connect and engage with each other and how we connect and engage with learners. So that is a real big challenge in the way that universities are structured and in the way that things are given priority or not given priority. But essentially, it really is about us being reflexive, being collaborative and being critical in relation to how we facilitate learning in our clinic, in our everyday settings. And so that for us is the framework that we are going forward with to develop that new ecological system that we think is critical to really embedding nursing in a more solid base to prevent some of these issues that happened during the pandemic to really, I think, derail nursing from its core values, and that I think has been a really quite traumatic for many people. And we should never be naive enough to think that we won't have similar kinds of pandemics in the future. And we need to make sure that we are ready for that, that our base is solid in relation to how we support nursing through those kind of things. And I do think Sigma, my last slide, Sigma has a lot to offer that in terms of creating these kind of networks where we can all really create this global learning community where we do hold person-centeredness at the heart of how we educate our future nursing workforce and how we support them through these kind of experiences. Thank you.
Dear Professor Brandon, thank you so much for your fantastic presentation. And thank you for your effort to change nursing care and education, and also for inviting us to rethink and reshape person-centeredness DNA, and for this translation of this framework to practice and specifically to education. Thank you so much. And please stay with us till the end so we can put questions. So we have a little change of plans. So once Professor Aida has an institutional commitment and she will have to leave. So I ask if anyone has any question to Professor Aida. So I have one. And the Professor Aida, I would like to know your thoughts on, despite all the challenges that we have during the COVID-19 pandemic, and there we are struggling with it, what do you think that we learn that we will certainly be maintaining in the future? What are the strategies, educational strategies that we learn that we can move and implement in the future? Okay, so Liz Westcott, I think, has other questions. So Professor Aida?
Well, I think that we learned that we can change. We can change with positive impact. And I think that we do that very well in this meantime. But as I said, I think that we must reflect about what these measures, which of these measures are to maintain, and which of these measures is not. It's only contextual and an emergency measure, and it's not to maintain. I am concerned about the possibility to the students to learn in other contexts more dependent of our reality. Perhaps the possibility of the school to have to management a unit, a health unit in the dependence, direct dependence of the school, for instance. And I am very concerned about to know, and the doctor, she has a very good communication about what we can do in e-learning and blended learning, and what we can't do with those kind of methodologies. I think that we have a lot of work in this matter.
Okay, thank you so much. And what are the positive learning outcomes that you consider that the students have during this process?
I think that the students too, they realize that they can do things in another way of do that things. Perhaps they be more autonomous, looking for the information and reflect about that information to distinguish what they could ask to the teachers and what they could seek for themselves. But nursing education is a social process, and it means that face-to-face classes are very important for the students. And I think that we can't do a large percentage of the courses without face-to-face classes.
Thank you so much for your thoughts and ideas. I don't know if Liz Westcott want to pose a question. Please, Liz.
Yeah, thank you to the presentations. They were excellent. I'd be interested to know, Brendan, I'm very interested in values-based practice, and there seem to be obviously many similarities with the model and the work that you've been undertaking. And I just wondered how much integration you've had between the kind of two concepts of values-based practice as well as person-centered care.
Yeah, thanks, Liz. Nice to see you. We've in this work, we've taken quite a broad approach to person-centeredness. So when we've been looking at curricula and looking at the evidence, we've not just been keeping it in a kind of person-centeredness as care that's almost in a box, which is how I don't come at it. And one of the reasons for that, I have to say, is that there are very few real examples of person-centered curricula. In fact, there were probably, we were only able to find 3 of those, and 2 of them I'm connected with, and there was another one. So we did look much more broadly around curricula that were based on values-based practice, that were based on humanistic caring, that were based on kind of explicit caring concepts that were, we wanted to see, that were still about the person and we're still focused on the person first kind of approach. Our issue with it is that what happens, and that's why we talked about this golden thread as being the kind of the key thing, is that what we saw in all of those curricula is that we see lots of really important and significant statements about philosophy at the front end of curricula. But then as they move through into modular structures or unit structures, it all kind of disappears, and we seem to revert back to technical skills, to competence, to behaviors, and the philosophy gets lost. And so our argument is that we really need to see a much greater integration and a much greater strengthening given to things like those shared values in the 7S framework, that they are held in all parts of the structure and the system and the style. And I think that's where we have still a huge amount of work to do in nursing, particularly to really make that explicit.
No, thank you very much.
And thank you so much, Professor Brennan. And let's keep the questions for Professor Brennan till the end, okay? So Professor Aida, thank you so much for being here with us today. It was great to have you here, and we know that you have a difficult agenda. Thank you so much.
Thank you.
It was great. Thank you so much.
For all. Thank you. Good evening.
So let's move on. And since we can't travel, and I think we miss it a lot, so let's just imagine making a trip from United Kingdom to Brazil. And now I will present Professora Ivone Evangelista Cabral. She's a nurse, a PhD nurse, and a postdoctoral researcher from pediatric nursing and child health. She's an adjunct teacher at the Faculty of Nursing, State of University of Rio de Janeiro. So her presentation will be on Brazilian experiences with a remote telenursing education. So Professor Ivone.
Thank you so much for your presentation. Hello, hi everyone. Can you hear me?
Yes, we can.
Oh, thank you so much for the invitation to be here and sharing this wonderful webinar and talk about this subject that's very, can I say, challenging for everyone, in a global perspective, as I could see until now with the other presentation. We are living really a global challenge, and also had many opportunity to overcome this moment, this sanitary crisis that we are living now. So my presentation here today, I will contextualize it from the Brazilian perspective. Brazil is a South American country with more than 200 million people. And we have very, how can I say, we are living now very dilemmatic problem related to COVID-19, because the situation since WHO officially declared the COVID-19 as a pandemic and a sanitary crisis. In Brazil, it was declared on March the last year. And we start a new program of education since March. The moment that the Minister of Education authorized the transition face-to-face classroom online to face-to-face classroom to online teaching. Since then, there has been a need to adapt the Brazilian health and education sectors, among others, to a new reality that implied the social distance or isolation. We never had a lockdown, but a social and distance isolation, controlling the movement of people through sanitary barriers or developing activities that implied agglomerations. As part of this context, we have in Brazil epidemiological challenge that affect the prevalence of COVID-19 has been high since the pandemic started on March 2020. Average of 2,000 deaths and more than 60,000 new cases daily. So we have to face with this challenge. And also as a result of this face-to-face lessons and clinical practice in the world's consultation clinics or laboratory simulation station was suspended, except for those students who were in internship training. I have to say that there is an exception in Brazil for health professional students. They continue to practice in a ward or in health services, primary health services and the primary health care services, and also in the hospital, because they were in the last year of the nurse and all health professional program. And we need to replace these health professionals in the health system. and also in the labor market. In this context of the information and the communication technology support was paramount to ensure healthcare and continued training of those nurses, students in remote activities. The previous face-to-face teaching had to be replaced by online modality and its tools, but many of them represented as my previous presentation, a speaker said, also many challenges to the continuity of teaching, numerous teaching learning attributes typical of the face-to-face environment were replaced by interactions mediated by technology with unstable internet connections and behind non-personalized black screens. The nurse-professor-student interaction and nonverbal manifestations are valued as human capital in the training learning process. However, it loses its specificity when seeing the limits of online technologies that modify, you have to say that, modify affective and psychomotor learning domains. We had adopted emergency remote teaching and the home office activities to prevent the spread of coronavirus. But what was the alternative to minimize the impact of the COVID-19 pandemic without stopping the academic calendar and continue the teaching learning process? We should guarantee the health professionals' output to the health system and the labor market, but not delaying student access to their baccalaureate. Quickly, higher education institutions which adopt the in-person teaching modality changed to emergency remote teaching. Nevertheless, many challenges has across this kind of teaching. And I organize in this presentation, think about the conceptual challenges, because we have to say that distance learning is not the same as emergency remote teaching. And the professor and the students need to understand the meaning of emergency remote teaching as different from e-learning, distance learning, or distance education. While emergency remote teaching, ERT, is a temporary strategy to ensure the continuity of teaching learning activities by adopting information and communication technologies, ICT. It has a purpose of recreating possibilities of teaching during an emergency or a crisis. E-learning means a form of education in which the main elements include physical separation of professors and students during instruction and the use of various technologies to facilitate student-professor and student-student communication. The other very important challenge we live it here in Brazil, it's a structural challenge. As part of this, it highlights the inequalities of access access to online and internet tools in Brazil. For example, a survey conducted by the Brazilian Foundation of Geographic and Statistics identified that the distribution of households with access and use the internet correspond around 8%, more in urban area than rural area or countryside. Households without any access were represented by 70%, and the reasons for not access or using the internet were high cost of internet and equipment, no service available in the area they live, and no interest in technology. Most users access the internet on their cell phone and half on their desktops. All these limitations influence professor and student performance to deal with screen size and equipment quality constraints. This data also illustrates how big the challenge was to overcome by universities with need which need to provide the students and professors with internet access in a country with a serious economic and political crisis that we are experiencing in Brazil. Challenges inherent to the learning environment mediated by digital information and communication technologies such as inequalities I've already mentioned, keep up with synchronous and asynchronous class and activities most challenging. However, it must be recognized that emergency remote training has negative and positive aspects with positive and negative impacts in the short and the medium term, especially on the quality of professional who will practice the profession in the future. In Brazil, the learning teaching process by adopting information and the communication technologies seems very similar to underdeveloped countries. All those countries are running online classes to make the education system more effective, despite inequalities of access to good equipment, qualities, and a stable internet system. An individual challenges must be considered because when we see the results of the pedagogical experience in remote teaching pose challenges for nurse students, as they mentioned that environment outside influences them, their performance, possibilities for prioritizing activities other than engagement in teaching, distraction in the home environment and no place reserved to attend classes, difficult to adapt to the change of teaching learning environment from university to domestic site, professor-centered speech limits student-to-student and student-professor interaction, and the virtual classroom environment inhibits students from asking questions and comments. An individual challenge is to preparation to deal with online platform and the pedagogical adaptations, increased intellectual and emergency labor overload from the construction of new materials, that the challenge that professors have to face with. Online spaces limit the emotions, perception of the students' content assimilation and the learning experience that require cognitive motor skills. For example, realistic simulations and hands-on lessons with real patient is more difficult in this kind of space. Uncertainties about experience and their application in students' skills for professional practice. In nursing graduation, mix theoretical and practical contents of nursing education for the development of skills and competencies based on clinical reality experience, propose innovative ways to encourage class participation and the group interest in the topic addressed and drain more energy to the professor to enroll the students in these activities. So what we did by knowing all the limits, all the challenges we have to live, I would like to share with all the audience an experience we have with interprofessional telehealth. An interprofessional clinical practice with students at the municipal Secretary of Health in Rio de Janeiro, summoned 280 scholarship students. Half of them belong to the Federal University of Rio de Janeiro, the place I was working during this time, and the university faculty members composed by physicians, nurses, psychologists, dentists, articulated with the team of the primary healthcare units for the supervision of the students in remote work. So the group of professors, I would like to share this experience and say thanks for my colleagues that work with me in this experience. From April 2020 to November of last year, a team of students, professors, and the clinicians at the primary healthcare units, we did phone calls, use app, video consultations with patients, and follow up more than 3,000 patients with COVID-19 and the chronic conditions, because as a result of the restriction of people circulation in the city, many of the patients could not have an access to the primary health care services. And we continue this attending of the patients supported by PHC unit and the clinician for a face-to-face consultation in the cases they need to go to the unit. What we did during this time, how were the work and teaching learning process with this experience? We're following up suspected cases of COVID-19 seen at the clinic, updated daily, home follow-up of respiratory symptomatic cases evaluated in the primary healthcare unit with weekly update, telephone calls with all listed patients using students' personal cell phone, insertion of students in a small group of WhatsApp and with professors and the clinicians assigned to monitor the work. Each professor was responsible for taking over one of the telemonitoring. E-monitoring took place within 24 and 48 hours after the first contact of the patient at the clinic, and prioritizing those patients with suspected or confirmed COVID-19 within 15 days. What we learned from this experience? We learned that during the COVID-19 pandemic brought us closer to telehealth as an opportunity to teach and learning, developing communication skill by phone, because we trained the students how to communicate by phone, building a bond with the patient and the family, qualifying listening of the student, understanding the family context and often including home visits by phone, with using video camera, allow us to know the environment where and how families live, and understanding the determinant and conditions of the health disease and possible interventions, training students from different professional health careers, all students practice together interprofessionalism with the philosophy of care centered in person, and the family and the community. Real clinical case discussions in the mirroring classroom allowed to problematize and learn each situation. As an opportunity of this experience, we had a new infrastructure of the university in our country with more tools to develop a teaching learning process. I do believe that we learned with this experience, and now we are more prepared for continue to blend face-to-face classroom with online classroom. A differentiated pedagogical glance, this is very important. Easier access to record class available on the platform anytime and as often as necessary. Synchronous classes allow active participation in the discussion, dialogue, raising questions, opinions, contests, and reporting experiences. Professors working on the front line of the pandemic, for example, enrich the learning experience of the students. A clinical practice through telehealth consultation is very innovative for our reality. In conclusion, I would like to highlight that adaptations, innovations, and the dynamizations in the way of student learning and development of optimization techniques for studies and creative work, awakening ideas and uncovering skills that were not explored before, like this communication through online tools, learning more about the use of online teaching through information and communication technologies, and the students change their study routines, managing their time with more flexibility. Remote work created bridges between the educational institution, healthcare unit, and the population assisted in primary care, dynamic and flexible work was developed. The demands changed as the work was developed to adapt to the unfold scenarios. Students, community health agents, professors, physicians, and nurses developed the clinical practice guided by the lines of care with the university. And the experience of remote guided learning was a concrete possibility to the health service and the population to stay closer, defining continued care, cultural, and the community components among the derivative perspective of the primary health care. So that's my my experience in Brazil, experience with the learning through online tools. And I would like once again to say thanks for the invitation and to share this experience and listen to the other speakers.
Thank you so much, Professor Ivone Cabral, with for all other creative ideas to adapt distance learning while maintaining the excellence of education, and also a glimpse of the future like telehealth. Thank you so much, and please stay with us because we are now moving to North America, and then we can put questions to Professor Ivone também. Also, sorry. Now we'll go to United States of America, and thank you so much, Dr. Kenneth Dion, for being here. So Kenneth, he's a Virginia Anderson and Billy Brown and Sigma Fellow. He earned his bachelor degree in nursing at the University of Central Florida, and his MBA and MSN, and a doctorate in nursing systems of the University of Texas at Austin. He's 40-year veteran of the healthcare industry and president-elected of Sigma, which he has previously served at a variety of levels in many capacities. And the nurse, entrepreneur, inventor, and scholar brings non-traditional and highly value-added expertise to identifying and advancing business opportunities within nursing locally, nationally, and internationally. So we'll love to hear all your expertise on nursing leadership, changes, and opportunities in a post-pandemic world. Kenneth, the stage is yours. Thank you so much for being here.
Thank you very much, and thank you for having me today. It's truly an honor to be with you. I'm not going to share my screen with you today so that you don't get to see a picture of my dog or my wife. We'll avoid the PowerPoint slides for the last presentation and just talk about a few concepts here going forward. Before I get started, though, I would like to bring greetings on behalf of Dean Nolan, the faculty, staff, and students of the Johns Hopkins School of Nursing. Very honored here to be here today and to represent Johns Hopkins as well as Sigma. So, building on what we've heard over the last couple of hours, we have had the same experiences at Johns Hopkins where we have had to pivot from traditional classroom learning to online learning very rapidly, implement new technologies like virtual reality to supplement the work that we were doing. So a lot of what I've heard today truly resonates with me. I empathize with the challenges that the other panel members have experienced. I think we've all gone through them, and we're looking forward to being on the other side of this, not forgetting where we came from, but at the same time learning from the experience and moving forward. And so what challenges are we going to face moving forward in education? Well, many of them are going to be exactly the same as we experienced before the pandemic. We're going to be challenged to find and recruit and retain faculty members. That will still be a problem for us in academia. We will still, in many places, be challenged to find clinical placements for our students. As we've heard today, we have done a great job of supplementing, if you will, our clinical experiences with alternative experiences with online and virtual learning, but certainly we can never fully replace in-person learning with virtual learning. So those clinical placement sites are going to continue to be important to us, but always will continue to be a challenge to find placements for our students. And then always for all organizations that lack of funding to pursue many of the initiatives that we would like to pursue. Because at the end of the day, many of the challenges we're facing at large will remain the same, and I'll touch on those in just a second. And then we're going to be back to some of the same familiar but cyclical challenges that we've faced in the past. Right now in the United States, we're seeing far more applicants than we're going to be able to accommodate in our schools of nursing. And a good deal of that is actually due to COVID, because nursing has gotten such great recognition around the globe for the work that they've done during the pandemic. And so many people now want to pursue a career in nursing. I hope that we don't see what we've seen in the past, where we have nurses that turn over very rapidly in the first few years of employment because nursing doesn't turn out to be exactly what they thought it was going to be afterwards. So I hope we don't see that same cyclical challenge that we've seen in the past. But we're going to see some new challenges after COVID as well. Certainly we're seeing changing expectations in our students, and we've seen that prior to COVID, but I think we're going to see it even more so as we move forward in terms of their expectations of us as educators, their expectations of the university and what's going to be provided to them, and what's going to be available to them after graduation. I think we'll still be challenged to figure out how we move to this new world of distance learning. I think that potentially and as we've already found out, there are tremendous benefits to it. Interprofessional education that we can do, bringing people in from around the world, but at the same time, it will have its challenges as well. I think the introduction of new technologies will continue to challenge us as a profession, and I'll talk about that a little bit more in a minute. And then I think that the introduction of some of these technologies that we've already talked about, augmented reality, virtual reality, and machine learning and artificial or augmented intelligence will also challenge us in the education domain. Challenges are going to continue to exist in practice. We're going to see an increased demand for nursing services. We have an aging population around the globe. Seemed that for the longest time, that seemed to be a very North American centric conversation. But as I traveled the globe and recently even in visiting in China, one of their biggest challenges is how are we going to deal with our aging population? So there's going to be that increased demand for nursing services. At the same time, we're having people leaving the profession because we've got an aging nursing population. And we have people leaving the profession because of their experiences during COVID. So many of these things, I'm not telling you anything that you don't already know. These are the things that we're going to continue to experience going forward. We're going to have to come up with some new strategies to figure out how to deal with some of these challenges going forward. One of the other challenges that I think that's going to impact us in academia that is going to come to us from practice is this concept that we're talking about, a practice gap, right? We have so many experienced nurses leaving the profession, taking their great knowledge and experience with them as they go, without having time to pass that on to the newer nurses that we're bringing into the profession. We're going to have to figure out how to work in partnership with our clinical partners to stem that gap in education. And then, certainly there is a changing ethos of nursing out there in many different societies where people come less to nursing for the calling that myself and my mother did, who was also a nurse, but really because of the advantage of the profession, that there is steady employment and opportunities for advancement and those sorts of things, and less to the dedication of the profession. And so how are we going to align incentives to draw them into the profession and also keep them into the profession? So these are all going to be challenges in the practice arena going forward. So how are we going to deal with many of these challenges? Well, I think it's really going to take somewhat of a threefold approach. And the first of that, and I want to go back to Professor Aida's comment about looking at nursing education. And I think we're going to have to absolutely look at nursing education. And I think from both Brendan's point about a person-centeredness perspective, but also just how we look at nursing education itself, and what are those global threads that have to be, or those golden threads that have to be in education globally. Because I think person-centeredness is important, diversity, equity, and inclusion is important, but also the business aspects of healthcare are also important. That's how we're going to solve some of these repetitive problems that we've seen in the past. So the idea of infusing some more of, if you will, business, for lack of a better term, into our curriculum somewhere, somehow, is going to be essential to resolving some of these repetitive problems. You know, we talk about economics a great deal broadly. We don't talk about it much in healthcare. We talk about it in healthcare, but not in nursing as much as we probably should. And I think we're doing ourselves a disservice, you know, not talking more about economics and nursing. And when we throw out the word economics, so often it's aligned with the concept of finance, and people think it's about money, but really economics is the study of power, and where finance and money is the vehicle for that power. And so if we are going to solve a lot of these global problems and have that proverbial seat at the table, then being able to speak the language of business and economics is going to be really important in terms of solving these problems. So integrating that into our curriculum is going to be incredibly important. You know, we wouldn't send clinicians out into the field, you know, not well prepared clinically. Well, I think we do our clinicians a disservice by not providing them the education around business, because quite frankly, going back to the point that was made earlier, by providing them nursing education, this is transformational for them. And I remember talking one time about the fact that we take, you know, young nurses who were basically maybe waiting tables or providing childcare and turn them into professionals, and now they have a professional salary, but we haven't given them the business tools of how to manage that. And that's just the very beginning of scratching the surface of what we need to provide in terms of understanding economic models and how those work, because at the end of the day, we need some new economic models, because the current economic models that we have are not serving us very well. And so I could talk for hours about that, but I'll move on, because one of the underpinnings of the new economic models is the technology that comes along with it. And that's another thing that we're going to have to get on top of our game about as far as the nursing profession goes. We've seen just rapid advances in the adoption of technology that has been driven by COVID. How many years have we been talking about telemedicine or telehealth? And now all of a sudden it's just been adopted very, very rapidly in many societies where the technology is available to be able to do that. Well, that's going to require different education, right? The introduction of robotics into our society and into healthcare is going to require changes in our curriculum and introducing these technologies. And then we get into the concepts of machine learning and big data, and how that is going to impact healthcare with precision medicine, and how we're going to have to integrate that into our nursing curriculum. And then this idea that as we begin to be able to gather more data through using tools like augmented and virtual reality and online learning, that we eventually develop and evolve to the point of having precision learning, where we're actually targeting education activities at the individual level based on the feedback that we're getting through the technology that we're implementing. Now, there's going to be great benefits to technology in the future, but there's always that flip side of the coin. There's the dark side to all technology. And nursing is going to have a very important role in these developing technologies. And so we're going to have to bring that into our curriculum. So as we implement augmented intelligence or artificial intelligence. Words are somewhat interchangeable these days. You know, it's going to be our role to make sure that implicit bias is not introduced into these algorithms. It's going to be our role to advocate to make sure that we're not increasing disparities with the implementation of technology itself or the byproducts of the technologies, these algorithms that are driving care protocols. So nursing is going to have to integrate this into the curriculum because this is going to be part of our role. And then all of the other opportunities that are going to be out there as well in terms of research, thinking about, you know, the use of robotics in the elderly population, the use of virtual reality in younger populations to change untoward behaviors. So there's going to be a plethora of technology and opportunity for nurses, but this is going to tie back to the economics again, because the people who are inventing the technology are not pouring the benefits of that technology back to society, and certainly in many cases not in terms of healthcare. And this is another place that we're going to have to advocate. And then finally, this all does come together again in another area that's very important to us as a profession, and that's this idea of conservation, right? Because we can see that well, let me rephrase that. We can see that an economic model based completely on consumption is not sustainable. We're literally burning the planet to the ground as we're busy consuming more things. So we're going to have to be involved as a profession that advocates for our patients globally for these new economic models, because if we don't do things to sustain our planet, how can we sustain our populations? It's just mutually exclusive. It's never going to happen. And so that again goes back to these concepts of how do we use technology? How do we use economics to change economic models to a model that is built on conservation and built on when people share their data, that they're reimbursed for the value of their data rather than data being capitalized in another way to make someone else wealthy than the person who should actually benefit from the data, the individual user. So my point is, and I'm going to wrap up here, is that I think going forward out of the pandemic, yes, we are going to be challenged with many of the same challenges we had going into the pandemic. Certainly the pandemic itself has illuminated challenges that we knew that we had, but really brought those to the forefront, and we're going to have to deal with them. But we're also dealing with some monumental global problems that nursing can truly have an impact on. But that starts at the very beginning of the nursing process and nursing education. And that means that we're going to have to begin infusing some of these topics that really haven't been common conversations in the nursing profession around economics. Maybe a little bit more about technologies these days, but really bring that into our wheelhouse and then get involved in how our profession and the things that we do can impact the global community. So I think these are things that we're going to have to be thinking about as we move forward, developing the nursing curriculums of the future and developing those future nurses. I thank you for your time today and welcome the opportunity to answer any questions you might have.
Thank you so much, Kenneth. It was fantastic. And thank you so much on your deepest reflections, I think, in nursing development. So education around business and economic models. So this was the main idea that I kept from your discourse. Thank you so much. And so I think that we have now a major opportunity right now on nursing practice and education. And it seems that this is about nursing contribution and also sustainability of nursing. So let's move on to questions. I ask to the colleagues that are here with us if they have any question to our dear guests. And I will pose just one question and then I will leave to the other colleagues. So what do you think, Kenneth and Brendan, and of course, Professor Ivone, about are healthcare systems prepared to maintain this philosophy considering the financial or economic constraints worldwide? What do you think on that?
Well, I guess you couldn't have teed up a better question for me at the end of that presentation. My answer is obvious. No, the models that we're working on are not sustainable. You know, you look at the wealthiest country in the world, supposedly the United States of America, and we fell down on the watch. I mean, we did an absolutely horrible job of responding to this pandemic. And, you know, if we can't help ourselves, how can we help other countries around the world which are less fortunate than we are? So obviously there's got to be a different approach, both on a national level, I would think, for many countries that I've seen, but I think also on a world level, there was not a coordinated effort made here. And it saddens me to think that, you know, and it is true that politics often comes ahead of the health of individual societies.
Thank you so much, Dr. Dion. So we have another, let me pass the question to Professor Brendan McCormack just to finish this question, this idea, sorry.
Yeah, I mean, I think I would largely agree. I think what we have seen and the work that's been done through WHO on the future of nursing and the global state of nursing, which Sigma have also done work on, then we can see that the models that exist are not sustainable, and that they largely are not fit for purpose in the way that global health strategies are changing and what we need to be paying attention to. I mean, I would just want to emphasize that the core of nursing is the person, however way we shape that or however way we want to put things around it. And I think we can build around that idea and we can keep adding layers to that, and that's infinite. I think what we have to be really clear, though, is about those core values. And my main argument is that we have let go of so many of those core values that we are now in a very, very fluid state where our identity and our focus is actually contested. And I think that is what we have got to get back to. I think we can debate forever the key components, the key things, but we have got to really return to a position where we are really clear about what the core nursing values are that we want to hold as our foundations upon which everything else gets built.
Okay, thank you so much, Professor Brendan. And now Professor Ivone.
Yeah, that's a good question.
Is it me that having internet problems, or is
Yes,
it with the Dr. Ivone?
It's Dr. Ivone.
Dr. Ivone. Dr. Ivone, we can't hear you. Maybe to get better internet, if you turn off the image. Or, okay. Maybe she will come later. I think that. Okay, maybe we can move on. Question from anyone would like to make a question to our keynotes, please, to Dr. Ken, Dion, Dr. Brandon, or even Dr. Betsy that stayed with us till the end. Thank you, Dr. Betsy.
Oh, sorry, Dr. Betsy. Okay. We have some questions on the chat, Lurdes.
Yes. Yeah. Well, Peter made a question to all the presenters that is how can we prevent nurses from leaving the profession after a few years, and how can nursing education help for that? I think that was a point that you touched, Ken. You said that we are now facing that some nurses are quitting from profession. Do you, or or Brendan or Betsy, do you have any, would you like to add a point on this?
I mean, I'm happy to make a comment about that, because actually it feeds into a lot of the work that we're doing around the nursing culture. You know, the evidence around this is very clear, and we don't need to be continuing to argue the case as to why it is that nurses stay in their roles or why they choose to leave, because we have a very clear evidence base about this. And the predominant reasons nurses leave their jobs is to do with culture. It's less to do with salary and those kind of things. And what I mean by culture, it's about support, professional development, well-being, and the kind of flexibility that enables nurses to live a full life outside of their day-to-day roles. And until we address that issue within our organizations, and this is where I do think organizations like Sigma have a huge role to play at an organizational level, not just within a nursing level, in terms of arguing the case for the kind of cultures that we know sustain effective practice, that we know are good for staff and good for patient outcome, then we are really not going to win that battle. And we really need a very sustained effort in ensuring that we address that issue. It is predominantly about nursing culture that makes nurses leave their jobs.
Dr. Ivone, you are already with us again. Would you like to make your comment, please?
Oh, sorry. It's I had a problem with the internet. It's part of this online moment we're living now. Yeah, as I already said, I think that the healthcare system, and not only healthcare system, but I would like to highlight the educational system. We have a lot of strength and economical constraint to adapt this new situation of online system of teaching, learning for students, and provide a good quality of internet system and good quality of equipment for keeping this kind of a branded strategy to develop a teaching learning process. So it's the technologies costs a lot of money. That's I would like to say. Technology costs a lot of money, and the citizen invests with his taxes and all the contribution, and we have to use this money, use these tools very rationally, with a rationality. Otherwise, we can't move forward. So I think that technology is not the final solution. I do believe that face-to-face and the relationship to the patient and the relationship to the students is most important than technology.
Well, we are now about 15 minutes late, so I have a question from Dalit Mota that I will would like you to answer, and that will close our key and answer sessions. Although I had another questions that I would like to ask you, but I will keep for myself. And so this is an interesting question also, is that the letter says the nursing curricula is so complex and we keep identifying more and more aspects that should be better covered in order to better prepare future nurses. Would more hours possibly be a solution, or specializing courses post BSN? Would like to answer?
I'm happy to kick off. I'm sure others have, but because we're so embedded in this work at the moment, then I mean, the question is absolutely right. It's one of the problems we have in nursing curricula. We call it the suitcase approach to nursing curricula, which is, you know, we pack more and more and more into our suitcase until we can't get any more in, and then we decide what do we want to take out. What we really have to do is to rethink that as a model, because for me that is about not being clear about the core concepts, core principles, core practices that we want to have privileged within nursing curricula and nursing education, and ultimately in terms of how nursing work. But unless we really develop some clarity about that, which is really what we are trying to do in our European project, then we will always have this kind of suitcase approach to curricula. And I don't think extending the hours is going to change that. It's not going to help in terms of nurses' well-being and being clear about the future role of nurses. So I think we need to stall that idea, and I think we need to really rethink what are the core building blocks we must ensure that every registered nurse is leaving our program with. And then the future is about professional development to take those forward, but it's not about more hours. In fact, I would argue should be about less hours, but that's a different argument.
I would agree with Brendan, even though I just advocated for a totally almost different domain of education being embedded within the nursing curriculum. We do have to figure out a better way. And part of this in the United States, and I can only speak for our registry system, goes back to economics. Again, here we are one country, and yet we have 50 different states with 50 different boards of nursing with different regulations in every state that we have to meet. And I will just say that, you know, kind of coming back to my point about the economics of it all and the World Health Organization asking us for, you know, to produce 6 million more nurses on top of the 40 million plus we've already got or more, you know, you put all of those voices together, those voices have power to change things. And that's what I'm talking about when I talk about, you know, the economics of it all. So no, I don't think that, you know, extending the curriculum is the right thing to do. But I think to Brendan's point, to reach a level of standardization that we can all agree on some certain basic principles across our profession would absolutely be huge for our profession to join all of those voices together on those particular things. Because you look at what other professions do, and they coalesce their power, if you think about it that way. And we tend as a profession, and it's just one of my pet things, and I'm sorry, we fragment ourselves and we fragment ourselves and we fragment ourselves until the point that we're so many disparate voices that we're not heard and we don't move change together. So I agree, not throwing more in is not the answer, but we all have to work together for better models. And that may mean having to give up a little bit too. That's always part of the negotiation. It's not adding more, it's giving up a little bit every once in a while.
Yeah. May I add a comment?
Yes, please.
Yeah, bridging on to what Professor Kenneth has shared about fragmentation of care. Indeed, the nursing, our patients' health and conditions are getting more complex with the multiple comorbidities, and rather than having to fragment and having to have more specialization per se, in fact, we actually I only can also speak only from Singapore's perspective. So we saw that shift, and what our school is moving towards is more of integration of the various aspects of the nursing curriculum. So previously, what we did was to learn to teach our students like anatomy and physiology as a component, and then the nursing care as a component. But in recently, we actually try to integrate all these different aspects into a single module, whereby we get different faculty members to actually share their different aspects of care on a particular system. So we look into the medical and the nursing aspects in holistically, and we try to work towards more of developing the students' clinical reasoning and critical thinking skills, and like what Professor Brendan has shared, towards a more patient-centered care, whereby we look at what are the patient's needs, what are the patient's healthcare concerns, and from there we address from there. So we are still in the midst of this experimenting the way how we conduct our curriculum to combine different aspects of the nursing fundamental knowledge together, pulling it together and integrate into the students' learning. Yeah. So just sharing from Singapore's perspective.
Okay, before closing this webinar, I would like to invite Mary Louise, the Sigma coordinator from Europe region, to, I don't know if you want to say a few words about the webinar from today, Mary Louise. Unmute, Mary Louise, please. Oh, you are unmute. Oh, yeah.
I am, sorry. Thank you very much. You caught me. I was just writing a congratulations for your 10th anniversary, which you are celebrating today as part of this conference. Absolutely stellar presentations this afternoon from all the speakers. I'm not predominantly in nursing education, but was kept the whole way through with all the presentations. It is really a phenomenal feat, as I say, to have perspectives from Singapore to America to Scotland, you know, to Brazil, you know, very, very interesting. And I hope that everybody else has enjoyed the presentations today as much as I have here listening. As I wanted to mention again, the chapter is 10 years old, and this is, you know, something that for us in Europe is one of our oldest chapters, apart from our Dutch chapter, which is slightly older. But to see you flourish over the last couple of years as a regional coordinator has just really been superb, absolutely stellar, under Aida Mendes, under Lurdes, Lomba, Anna Filipa Cardoso, Marcia, Filipa Ventura, and I'm going to miss a load of names out. I'd like also to thank Paulo Costa and Rafael Bernardes and all the people behind making this technically possible today, because it's been really a very professional standard to attend, even with the music at the beginning. I just want to say absolutely, you know, you can't get a better region than this when there are chapter and boards, you know, that just break the glass ceiling, and the caliber of the presenters today has just, you know, blown me anyway away. So thank you very much, everybody.
Thank you, Mary Louise, for your kind words. Before we finish, I would like Dr. Anita Catlin to invite her just to present the research. She has a request to us, and Dr. Anita, would you like to say what it is, please? Rafael.
Okay. Yeah, I think, am I good?
Yes, Anita,
Yes.
you may go
Okay,
on.
so just before you leave, and especially Betsy, perhaps, thank you all to all of you. I just wanted to announce an international study that we're doing with the Portuguese chapter and an American chapter, Lambda Gamma, at Sigma Sonoma State in California. We're doing an international study on the effect of COVID on pediatric nurses who needed to care for adult patients. And we posted our recruitment letter on the chat. If you could disseminate this in your countries, we would be so happy. Thank you so much. And again, Lourdes and Mary Louise, you know, this is the best.
Thank you, Anita. Thank you for your kind words. So I will not make the resume because we are really late by now. Just want to finish this webinar. Thank you again for our stellar presenters. Thank you very much for making this event so grandiose, so nice. Thank you very much. Bye.